So I started this presentation and this project probably about 6 months ago, maybe 7, because A campus is a mixed acuity unit. So we're 12 ICU beds, 12 PCU beds. And most of our nurses have only worked on the CCU prior, so they were unfamiliar with discharge practice and discharge education. Um, and obviously,
Hanging.
I worked on Silver 11 prior to working in campus, and I also worked outpatient as an APP in hepatology. So I would constantly see like a lot of disconnect between inpatient and outpatient, and then factors that were driving patients back into the hospital. So I wanted to, that's obviously a big catalyst for readmission. So that's why we started this project. So discharge education and planning should always begin on day 1. Obviously, improper discharges are responsible for many things such as reduced patient compliance, patient safety, patient mortality, and obviously increased readmission rates. So the aim of this project was to help reduce readmission rates along the cardiovascular medicine service line and improve nursing practice at the time of patient discharge. So what areas can we improve? So before I started this, I did a survey monkey amongst my colleagues and asked them, like, what methods are you using for education? Are you doing teach back? Are you doing videos? Are you giving out reading materials? I also asked, like, how often are you ensuring that follow-up care is provided, and how often are you asking, like, are you always able to make your follow-up appointments? Do you have access to your follow-up appointments? How often are you able to refill your medications? Do you have trouble refilling your medications? Do you have trouble forgetting to take your medications? And then how often is there a support person in your house that can help you with these things? And the other thing is, do you have necessary self-monitoring equipment? Do you have your blood pressure cuff at home? Do you have your heart rate monitor at home? Do you have your scale at home? Do you have your pill box at home? All of these things are something that are resources that we can help give patients, which I'll get into. And then the big thing is, how often are you completing a NED reconciliation, either with another colleague, just another nurse, or the unit pharmacist? All right, so why is this important? Obviously, we know that 30-day readmission data shows that the Agency of Healthcare Research and Quality has shown that 1 in 4 patients with the following diagnosis will be readmitted. The biggest one is congestive heart failure, which we see all the time, schizophrenia, and then renal failure. And then they've also showed that nearly 1 in 5 patients with the following procedures will be readmitted. Number 1 being amputation of the lower extremity, and then 2, the second one is heart valve procedures. So that's our TAVRs, mitral valve replacement. And third is a debridement of a wound or infection or a burn, which we also see throughout our patient population as well. Okay, so patient education. So it's obviously essential to help setting up our patients with success for discharge. So this is taking the time is one of the big things that will help keep our patients from coming back. So most data shows that 78% of patients just in the ED have some comprehension deficit in one area of another of their care, whether it's how to take their meds, how to check their blood pressure, or coordinating follow-up care. And a randomized control trial at the University of Michigan showed that 1 hour of discharge teaching with a nurse can help reduce readmission by 35% and increase medication adherence. And it's really important to just take the time and be patient, get a colleague to cover you while you're doing discharge, because this is obviously very overwhelming, especially patients that are coming in with their first MI and we're starting them on GDMT, and it's a lot to learn. So it's really important to be patient and understand that they're very overwhelmed. So take the time to ask, how do you learn best? I'm an auditory learner, so we could get you a YouTube video. We have QR codes on a lot of our education materials where they can watch and listen to videos, doing teach back, demonstration. And then we also have on each of our units the Penn Medicine specific heart failure information. And always, if it's something that they're, learning to use their glucometer for the first time, learning to use a blood pressure for the first time, it takes about 7 to 30 exposures for an adult to really master a task. So if you're gearing patients up towards discharge and they're going to go home on GDMT and they're going to be taking Vitope or Valsartan or whatever it may be, get that blood pressure cuff up to the unit as best you can. Watch them take their blood pressure every morning with them so that they get in the habit of doing it and they're familiar with the equipment. All right, so heart failure specific education. So obviously pharmaceutical education, going through what is a beta blocker, what is an ACE or an ARB, what is your diuretic, what are some contraindications why we shouldn't be taking it, is our blood pressure too high, is it too soft, is our heart rate too high, potential side effects, food interactions. We know grapefruit messes with everything. Obviously avoiding NSAIDs, we all love them because they're fabulous, but not our heart failure patients. And then always, dietary, which we'll get into a little later in this talk, restricting of sodium and free water intake. It's always important to educate your patients, where salt goes, water goes. We can provide them with a daily weight chart that they can put in their bathroom. So after their first void in the morning, they can log their weight. And we also can, pass these out. We have them on our floor now. I think most of our cardiology medicine services have a daily weight chart that we can put in their discharge packet. So we have, when we were going through this, we were like, should we put in a new dot phrase? Should we do all these things? But we didn't really need to reinvent the wheel. Epic has a ton of resources that I think we're just not familiar with, that we should be utilizing. So we can easily translate education and discharge materials into a patient's preferred language. This is under the clinical reference tab in Epic, and you can it's another drop down, and you can just select the language, whether it's Spanish, Mandarin, whatever that they need. We also have heart failure booklets on the unit that are stored in patient, and I believe that they also come in English and Spanish that we can provide with our patients. This is also true for the discharge summary and the after visit summary. So this is just a little picture I took from Epic. So you can click clinical resources, and then this is the drop down. And so if you want to give them information on beta blockade or whatever we're setting them up with. We also have interpreter services. So if they have, I one time had a patient from Cairo, and we obviously didn't have that. So we use Quantum, and they were able to translate the ABS so that it was appropriate, so the medical terminology translated appropriately. And then we also, have in-house translators that we can arrange so that at the time of discharge, while we're doing education, we can use them so that there's nothing lost in translation. All right, so it's really important for patients we know to weigh themselves every day. So this is moving forward into what they can do at home to keep them out of the hospital. So they can track their weight in the journal. We can provide them with the daily weight chart. Obviously, a sudden weight gain is that we're building up fluid. We know that if we're gaining 3 pounds in 1 to 2 days or 5 pounds within a week, we need to call our provider. I recently just had somebody who came in with a 15-pound weight gain because they were unaware that they could reach their provider, who is a Penn Medicine provider, through the My Penn Medicine app. So I said, let's pull up the app together, message them about your weight. They can always give you an extra dose of diuretic or augmentation like metolazone, and then we can have them follow up with labs outpatient in case they need a little magnesium or potassium, make sure their creatinine and bump as well. We didn't dry them out too much. So these are all things that we can easily manage outpatient. And then nutrition is a big thing as well. Obviously, we want to limit sodium and maintain a good fluid restriction, 15 to 1,800 milliliters a day. Obviously, sodium makes you retain water, which can relate to all the symptoms of a heart failure exacerbation. Try to let them know that we want 2,000 milligrams of sodium per day. If patients are unfamiliar how they can do that, we can always print out a label, like a nutrition label, so that they can see how much sodium they're taking in a day. Other things we need to educate is eating more fresh foods, salt-free products, less processed foods, showing them, a liter is about 1 liter of soda bottle a day. Some patients may not be familiar with how much fluid a liter is. And then we should always be using our unit dietitians. They're phenomenal resources. And a big thing that I really appreciate about this project is that I got to work with a lot of diverse nurses. So their diet, we this is an inner city hospital. We get patients from all walks of life and different cultural and ethnic backgrounds. So it's really important to take that into consideration, because what I'm eating at home is not what they're eating at home. Not everybody is going to want to eat a Mediterranean diet, you know?
Yeah.
So we need to be cognizant of that. And then another study from Michigan showed that nearly 15,000 patients across hospitals for serious heart conditions and heart attacks, a lot of it was shown that just dietary counseling can reduce these cases as well. So we made a sample menu. And, you know, other ways that we can add flavor, whether it's fruit juice, you know, using vinegar or herbs for fresh flavors. So we can talk to our patients about, like, what foods are you eating? How are you providing extra flavor? I'm on a bland diet. I don't put anything in my food, but other people, they use other things. You know, salt obviously isn't our friend. So we can use a little teaspoon of hot sauce, you know, just being cognizant of the sodium content in it. We can use things like basil, parsley, or thyme. And it's also to, you know, obviously not everybody has access to these things. So it's always important to make sure, you know, where are you getting your food? Are you in a food desert? And we can always use social work and other of our resources to help them with, you know, locate areas that they can get food that's affordable as well.
And now they have the salt-free herbs and all.
Oh, great. Yeah. I'm going to turn this over to Lexi.
Actually, can I grab it?
Thank you for it.
So now to go into follow-up care, we always like to remind our patients who are admitted under the heart failure service of any upcoming cipher calls. Usually the goal when we discharge patients is that they're seen in clinic within a week of discharge. Sometimes depending on availability of the providers, it can be pushed up to like 2 weeks, but ideally we want to see them, especially because when we leave, a lot of medication changes are made with diuretics. We want to check lab values. We want to see how they're responding to their treatment. So we always want to confirm that follow-up care has been scheduled and with the appropriate specialist. A lot of times too, recently I've been seeing that when people are discharged, it says that sometimes it'll be scheduled within a week. So I really emphasize the number of the clinic and make sure that they know to call within a week in case their appointment wasn't scheduled before they leave. And confirm that transportation is secured. That's a big thing too. A lot of patients will miss their follow-up appointments because they don't have a way to get there. If transportation isn't easily available, we can have social work help to provide resources. If patients do receive Medicaid, they also qualify for medical assistance transportation. So these are resources that social workers can help coordinate. And there actually is a hub shuttle for patients in surrounding zip codes. So we can provide that information to people that need a ride to their appointments. Jenny did mention the MyPen Medicine app. It's very convenient. It gives the patients their appointments, their lab values. They can see notes from their specialists, and it also gives good information with ways that they can message their doctors, especially how you mentioned if they're noticing that their volume up at home. A lot of them will try to, you know, increase their diuretics before making them come in just to see if that helps. So that's really a convenient and helpful app. At the end of the discharge paperwork, it always gives a QR code or a website with information if they don't have the app or the site that we can help them set up. But we included the link here too as well if they need help setting up their MyPen Medicine account. In terms of lab monitoring, so medication adjustments during admission do warrant lab follow-up after discharge just to see how their body is responding to their diuretic dose, how it's affecting their kidneys or their electrolytes. So usually they have labs scheduled to be drawn within a week after discharge. So something of note, the lab scripts, if you get your labs drawn within the Penn Medicine Network, you technically don't need to present the lab scripts. It's usually just for outside labs, but on discharge, I like to just give the lab script anyways, just as a good reminder, like, hey, you need to get these labs drawn. Sometimes they'll print on the computer. They usually print automatically at the computers. If you find, I know some days depending, like they'll print a day earlier than discharge, or if they don't leave the same day, you'll forget they're on the computer. People put them in the sharps. So you can always reach out to your covering provider. They can reprint them. I know there is a way in Epic that we can do it too. I was like, I don't remember the exact steps, but I know there is a way that we can print them too. Polypharmacy is a major contributor to readmissions, and as you know, most of our patients, they can take up to like 14 pills a day in the morning. Also, just like reiterating to patients, I had patients, a lot of our meds are Q6 or Q8, and I've had patients say, well, I take one big gulp in the morning and one big gulp in the evening, and that's like not helping with how effective these medications are to our patients. So just reminding them of like when to take them. I always go through, sometimes you have patients that don't want you to go through like when things are due at what time, but I always like to do that just to reiterate how often and when you should be taking and how much of a medication you should be taking. Research has shown that for each additional medication prescribed, the odds of a prescription monitoring increased by 16%. And you do have patients come in, lightheadedness, dizziness, passing out at home. And sometimes you're like, you're taking too much of a medicine? Are you not familiar with what you're taking? Are you not taking it at the right time, etc.? So the ANA does recommend the use of 7-day pill boxes and blister packs to help with adherence. We can also set reminders for patients on their phones if they're having difficulty remembering when to take their meds. And we can also work with social work to see if patients qualify for those blister packs at home. These are just some extra medication tips from the heart failure education booklet, and these, like we said, are located throughout the unit, but just reminding patients when to take their medications at the same time every day, using a pill box to help remember. Always take your medications when you travel. We've had patients go away on vacation and they come back and they're up like 15 pounds. So they didn't take anything with them on their vacations. When to call for refills, where are you getting your refills from? Knowing the names of your medications, what it looks like, how much you take. Sometimes there's discrepancy because like our amio, some people take the white pills, sometimes here they're pink. I've had patients be like, no, I only want the white pills. So just really educating on medications, what they look like, how they can come in different shapes and colors as well. Keep a list of your medications. Important not to skip doses, especially on DOACs or blood thinners, and never take more than prescribed. And then we talked earlier about the medication reconciliation. Compare the patient's admission medication reconciliation to the list on the ABS. A lot of times it'll print like some people will take like different over-the-counter vitamins or things that we aren't giving inpatient. I always like to confirm with the provider, especially with medication changes, is it still okay for them to take this at home? Sometimes like natural remedies will negatively impact like our heart failure regimen.
Like ginkgo
meds.
biloba.
Always, yep. So this is done to avoid medication errors such as omissions, duplication, dosing errors. I feel like most people think the med rec only the providers can do, but you guys can look at it in the chart as well. That's totally okay to do. That home medication list is under the navigators tab, which we'll show you on the next slide.
If you go to navigators under admission and you'll see medication. So this is their outside, what they're taking at home. So making sure that nobody's getting told to take metolazone every day or something is really important. So it's always important, just if the pharmacy's not here, especially on weekends, making sure that there's not duplicates of things. You can always compare this with a colleague to what's on the ABS.
And then self-monitoring materials. So like we said, we give patients, blood pressure meds, diuretics. We, especially our patients that have arrhythmias such as AFib, do they have a heart rate monitor at home, blood pressure cuff, a scale, glucometer? If they do not have these materials, we can order these materials up. They can be ordered by the covering provider in Epic and be delivered by CDR prior to discharge. So that's something that I'm like, do you have a scale at home? A lot of people like the little pulse oxes, but I always tell them they're pretty cheap over the counter too. If you happen to go to a drugstore when you're picking up your meds, you can get one of those just to see your oxygen as well. So we do have some of those resources available that we can give to people before they leave, but I always like to reiterate to make sure they have them at home.
And these are just the resources that I use to help facilitate this book. So we have any